Now, moving on to our third section, that is what may be also be associated with fracture is a delayed union, non-union, a malunion. Usually fractures are fixed in form of a surgery, but this fracture fixation may lead to all these kind of a delayed kind of a problem, such as delayed union, non-union, and malunion. So what are the late complications? Late complications include delayed union, that if we have fixed a fracture but it's not healing as it should be healing. Usually a fracture gets fixed in 4 to 6 weeks if it's conservatively managed, or if by 3 to 6 months complete healing has occurred and remodeling has started. But if the remodeling does not start and complete healing does not occur, patient may be having a delayed union, or the patient may be in a state of a non-union as well. Usually the causes could be biological, which could be inadequate blood supply over there, severe soft tissue damage, for example, even the periosteal damage, a periosteal splitting has occurred at the time of surgery maybe as well, or periosteal stripping. This can all lead to delayed union. Certain biomechanical factors may be important as well, such as imperfect splintage or imperfect fixation, or sometimes over rigid fixation is done because there's not enough movement to the fracture site, and this micro motion is not present, can lead to slow callus formation and eventually may be leading to delayed non-union. Or this could be infection. There may be a subclinical infection which may eventually not lead to only delayed, eventually progress to non-union as well. Other certain patient-related factors which could be the patient may be immunocompromised, patient may not be taking a healthy diet, or there may be patient may be not putting weight on the limb for adequate amount of time, so that it can cause the normal progress to union. Now coming to the conservative treatment, what is the treatment if the patient is having a delayed union? Then initially is our non-union union, that is to eliminate any possible cause of delayed union. Now if it's related to the biological causes, then probably it's not that easy, but if it's due to infection, we have to make it sure we have to get rid of infection form, either give oral antibiotics or IV antibiotics, but we have to make it sure that we get cultures and we have to get rid of infection. If it's patient-related factors, if the patient may be not having a good diet, a patient may be immunocompromised for any reasons, or taking steroids for any other disease as well, then this may be hampering its union. Our patient may be on alcohol, or patient may be smoking as well, then patient needs to quit alcohol and smoking, patient needs to get rid of the steroid use, whatever for he or she is using for, and we have to, patient needs to start at least putting partial weight bearing or some amount of weight on the limb, so that I can actually produce healing and accelerate healing eventually. Other is promote healing by providing appropriate environment. Now when I talk about environment, is actually removing all those factors which can hamper union, for example alcohol, smoking, steroids, and even malnutrition, and providing adequate immobilization should be sufficient, and patient should start at least partial weight bearing over it. Then fracture loading or stimulus for union. Fracture loading is when the patient starts bearing some degree of weight on it, gradually increases the weight bearing and eventually leads to union. Then if it's, for example, it's operative, if it's infection, or if despite all these measures the patient has progressed to non-union, and then probably operative intervention is sometimes required. Then it could be in form of internal fixation with bone grafting, or it could be, usually when we are doing this kind of internal fixation, we need to remember we need to do least damage to the soft tissue, especially the periosteum stripping needs to be minimized, and optimizing the biology, for example the biomechanical stability of the joint and the bone is important. We need to respect the soft tissue. By damaging too much soft tissue, especially the periosteal stripping, would further compromise the blood supply to the bone. The other option of non-union treatment is basically depending upon what is the causing the non-union. If it's contact and alignment is the problem, then we can redo the surgery with do some kind of a fixation with bone grafting. If it's stability and stimulation is important. Now, depending upon what type of non-union it is, then we can move to a certain type of treatment. If it is poor soft tissues from either injury at the surgery, this could be one of the cause of non-union. For example, patient had an open injury, there was grade Gustilo 3B injury where there was periosteal stripping, massive soft tissue trauma as well, and probably this is the reason the patient does not have an adequate blood supply over there for the bone to unite. This could be local infection, as it's an open injury, there may be associated infection as well, or could be associated drug abuse or anti-inflammatory and immunosuppressants patient may be taking. NSAIDs which actually decrease the bone union, so they have to be prescribed consciously. Non-compliance with the part of the patient. For example, patient may be smoking and taking alcohol. This may be also hampering the union, which has to occur at the fracture site. Now, conservative treatment of the union is actually in form of removal splints. If it's hypertrophic type of a non-union then there is the bone is not united, but vascular supply is adequate. The other type is atrophic type, in which there is not union as well as there is not enough vascular supply for the bone to unite. This could, for treatment of hypertrophic non-union, this could be in form of functional bracing, which may need prolonged. For example, for 4 weeks, we can continue it for 8 weeks or 12 weeks. Then stimulation of bone union can be done as well in form of pulse electromagnetic fields, low frequency pulse ultrasounds. Although they are in a process, certain scientists have published papers over it, and they have shown some amount of benefit as well. But other operative treatment for hypertrophic non-union is rigid fixation alone in terms of internal and external fixation along with the bone grafting, because there's adequate blood supply over there. 3 different types of hypertrophic non-unions, which include elephant foot type, horse hoof type, or oligotrophic type. But remember, the bone union is not there, but blood supply is there. So if you fix it internally with bone grafting, probably with taking care of the biomechanical and biological factors, probably the union we can achieve union. Coming to atrophic type, usually there is a fibrous tissue, sclerotic bone ends. They are excised because what happens is there is non-union along with the fibrous tissue present in between the bones, along with the decreased blood supply as well. Usually sometimes there is a massive bone loss as well. For that, we need to bone advancement procedures. The bone transport needs to be done in the form of laser off. Now coming to the malunion. Conservative treatment, for example, distal radius fractures or even of the tibial diaphyseal fractures, can lead to malunion. That is, although the bones unite, but the problem is the criteria which is acceptable limits of union is actually not achieved. That there is increased angulation and there is increased rotation, which may lead to be problems for the patient. If, for example, a patient may not be able to carry his or her daily livings due to decreased range of motion or decreased malalignment of the leg. We need, for treatment of malunion, first and foremost is the X-rays. Check the position of the fracture. Then check the rotational deformity. For example, if it's conservative treatment is going on tibia fractures, then we need to look at the femur in the tibia, then humerus in the forearm, and metacarpal fractures as well. Not all the fractures are treated, femur fractures are treated conservatively, but in children, yes, we can apply spica. And in case we have applied conservatively the hip spica for the femur fractures, this can lead to rotational malalignment as well. And sometimes there is so much gross manipulation that is actually not remodeled over time and leading to malunion or rotational malalignment. Now, what is the treatment? In adult, fractures usually reduced to anatomical position and fixed in form of plates and nails. In children, angular deformities usually remodel over time, but we need to remember that if it's beyond a certain degree of angulation, for example, in radius ulna, usually the upper limit is 30 degrees, and beyond that, they won't remodel over time. So we need to remember that if they're falling in certain specific criteria, well and good. Otherwise, we have to fix it. Lower limb usually shortening can occur, and usually almost up to 2 centimeters can be tolerated. But anything beyond 2 centimeters usually not tolerated and needs surgery either in form of contralateral epiphysiodesis, contralateral shortening, or ipsilateral lengthening. Then it depends whether it's less 2 centimeters, 2 to 5 centimeters, more than 5 centimeters of shortening is present. And that may need limb equalizing procedures. And we need to make it sure that when we are dealing with LLD, patients' expectation must not be ignored. And we need to make it sure that patient is on board for whatever the treatment, because sometimes that treatment may take up to years, maybe more than one surgery, and maybe 2 to 3 surgeries at times. And when X-ray is of utmost importance, because when we are dealing with limb length discrepancies, we need to remember this, because usually they're children, they will eventually grow. So we need to first understand how much limb length discrepancy they will develop when they will become adults. So we have to treat it accordingly. In this section, we have briefly gone through one of the major complications of fractures, such as one of the late complications, which could be in form of delayed union. It could be in form of non-union, or it could be in form of malunion. Malunion is usually associated with conservative treatment, but we need to remember that we need to rule out what is causing the delayed or non-union. If it is biological factor, we need to fix it. If it's patient-related factor, we need to remove that factors. And if it is related to biomechanical stability, then we may have to go for operative re-op surgery and go for internal fixation along with bone grafting. Thank you very much. Keep watching sqadia.com.